Okay, this one would be here. Okay, then is it
these microphones?
yes.
Yeah, this is okay. But you see the what?
I'll check this one.
The speaker has moved to. And how do I do this? Like this? So with the mouse you have to do here, Frank. But I can do it with this one. Yeah. Okay, if it works. Okay. My task was to tell you something about the literature of last couple of years. And yes, John, thank you. I did my PhD on hypertrophic scars in keloids, especially hypertrophic scars. And this is my article to summarize the PhD study. And I thought, well, as hardly anything changed, but I think slowly by slowly, this works? Okay. But what you can hear and what you find in the literature, that slowly by slowly, I think things are changing, and they have changed. And in the literature, but especially hypertrophic scarring, but they were mingled up with keloids, that if you look at the phases of wound healing, all the phases are hampered. Everything in all the phases, there are changes, and they're not like normal. And it ends up with a lot of remodeling and less apoptosis and more collagen production. But what we saw as well is that in all the literature, hypertrophic scarring is mixed up with keloids. And if you look at, you see it, if you look at the hypertrophic scarring, then I think hypertrophic scarring also grows beyond the borders of the normal scar, because the inflammatory reaction to heal gives the redness and gives a change of architecture of the normal skin besides the scar. But you can see below that there's equal traction on this abdominal scar, but on some parts you have hypertrophy and other parts not. And that's because the normal skin has changed, but the amount of inflammation is limited compared to keloids. So I had to look just at keloids. And I looked at some reviews. And because in my mind, I still had the wound healing stages, and because the literature, especially my own paper, was by different phases, I looked at the keloids in some phases as well. And if you look at the literature regarding keloids and hemostasis, there's no literature. And that's because there is no normal sequence. Because these kind of scars, these are not scars, these kinds of lumps, these kind of tumors, they appear by itself. They appear after a full small inflammation. They are not appearing after a wound. Also, these kind of scars, well, maybe due to a piercing or due to an operation on the ear, then you get a keloid. And then you can say, well, it's in the same process of a scar. But these kinds of keloids, they appear not during the inflammatory phase, they appear at a year or even later following surgery. So no normal wound healing sequences. Keloids are not a wound, but I think that all of you interested in keloids now really know it's not a wound. So I think we don't have to discuss that anymore. Next talk, next year, I will take it out. So the origin is not following the normal wound healing stages. It's more tumor-like. And there's the genetic susceptibility, although there were not found genes, but it's more epigenetic. It's aggressive, resistant to treatment, high recurrence rate, and abnormal methylation and reduced microRNAs, and it has a dysregulation of long-coding DNA. And even patients suffering from these benign-like tumors, they have a higher chance of skin cancer and a higher chance of pancreatic cancer compared to people not suffering from keloids. It's tumor-like, but there's something strange. If you look at all those kind of scars, and we see them all, we know them well, it's only skin deep. That's quite strange, because why? It's not invading. It only invades the skin, and it's benign tumor-like, but it's almost not complete like a benign tumor. It's different. And if you look at a keloid like this, it grows outside the borders, but if you take it away, then it's only skin deep. Quite strange. So it's only a part of the skin. Hemostasis, no literature, but when we look at inflammation, I'm a clinical person, I'm a plastic surgeon, and I always look at my patients, and all the patients suffering from keloids have a kind of dimple or keratosis pilaris or fungal acne. They all have something extra inflammatory-like in their skin. That's strange as well. And what you can see in literature is that inside the keloid, you have an exaggerated, prolonged inflammatory phase. And inside the keloids, there's a high number of all kinds of immune cells. And those immune cells produce, of course, a lot of cytokines. Those cytokines activate fibroblasts and activate myofibroblasts to produce collagen. So it's an exaggerated inflammatory tumor. And it was proposed that it's autoinflammation. So you have the inflammation, and inflammation is like a loop, and it gives more and more inflammation. And in those keloids, you have a lot of signaling pathways, and they're all changed. So almost all the pathways we know in healing are changed and are higher. And that actually involves the cytokines like TGF-betas and interleukins to activate fibroblasts and give the keloid formation. So a lot of signaling different pathways, inflammatory based. And that ends up with a keloid. But when you look at the patients still, then you see that the keloids grow maybe alongside the blood vessels or alongside the lymphatics. So it grows in the skin, probably alongside the circumstances where you have less, how do you say that? Well, where it's more easy to grow for that what's giving the keloid, maybe the fibroblast, maybe something different. And we looked at the proliferation phase, and then we saw that there is an abnormal endothelial dysfunction. So blood vessels are involved, like you can see here and here. And the center of the keloids, blood vessels disappear. And at the end of the keloid, there is still vascularity and dysfunctional vascularity with dilated blood vessels and edema. And those blood vessels are different from normal blood vessels. There are more blood vessels, but centrally there are less. So at the edges of the keloid, you see a lot more blood vessels. They give pro-angiogenic factors, and that increases proliferation, migration, evasion of collagen and fibroblasts. And where normal wound healing disappears, that's a way of thinking of wound healing again. But the keloid is quite different. So those blood vessels are dysfunctional, dilated, And the endothelial cells can change into mesenchymal collagen-producing cells. The permeability is higher, and there is more interleukin and inflammatory cytokines. And that's also producing a loop to let the fibroblasts produce more collagen. And here you can see that out of one of the papers that hypoxia is involved, angiogenesis, and in the end, producing the collagen. So it's also very easy to treat an excessive scar by pushing the blood out of it, and that's a very fast treatment. So you see that part of the appearance of an excessive scar is dilation and edema. And she talked about the genetics, and epigenetics is different as well in keloids. And it ends up with the excess matrix. Okay, this was fungal acne. I never heard of it. And I thought, well, maybe fungi are involved in keloid formation. And I did some talks on that. And there was a case report showing us that indeed in keloid there were found fungi. And of course, keloids look like fungi. So why is the microbiome not involved in keloid formation? And that was my thought. And especially in Brazil, they see lobomycosis, and that's a fungal infection as well, and it looks like keloids. It is involved in keloid-like production. And a recent study showed as well that in keloids you have more fungal, like malacia, that was found inside the keloids compared to normal skin and non-keloid tissue. So there is a relationship with keloid formation and fungal infections. But what we did, we took some biopsies and sent them to Germany to a lab. We didn't find any fungi in our keloids, but maybe the difference between different people, different locations, that's possible. And the microbiome does not only involve fungi, but also, of course, viruses and bacteria. And it seems that the microbiome dysbiosis activates interleukin-8 and can let fibroblasts produce collagen. And what was found as well is that what you can find a microbiota in your abdomen, in your stool, that the metabolites were found have a relationship with activation of fibroblasts. So a diet with more fibers, omega-3 and quercetin, reduces the active metabolites in the stool in your abdomen to reduce fibroblast activation. And it was found that bacteria related to keloids are decreased in bacterial diversity and increased in some species like, well, you can read them. So in another study, it was found that the gut microbiota are related to keloid formation. So keloid formers have different gut microbiota compared to non-keloid formers. And that was found on the skin as well, that different species were found in keloid and non-keloid formers, keloid in the skin and the skin where is no keloid. So to summarize this, different populations of bacteria were found between keloid and the surrounding skin, but also between keloid and non-keloid formers. And this was a recent publication that they also found different in the microbiome differences. And what we found in a study a couple of years ago is that where keloids appear in, there are less macrophages. So if the microbiome is involved and the microbiome is active, and you want to have killed those bacteria or fungi, then you need macrophages. But especially on the spots where you have the keloids, like presternal, shoulders, jawline, there are less macrophages. And no research was done until now if there is a relation with viruses. And the current therapies, we all know a lot of medication, especially corticosteroids, 5-FU, but it seems that the combination of 5-FU and corticosteroids is the best. Less recurrence rate, and it's better to combine them than to do corticosteroids alone.
They're just seeing that.
What's the problem?
You see this one?
The Zoom people are only seeing this screen, they're not seeing the whole screen.
This
is
was
what you
only my first slide. I will not do the talk again, sorry.
That would be share from here. Share this one.
How you design the slide. You're good at that. I like the biblical stuff.
Is it?
You see the right.
Yep.
Please continue.
It's very interesting that the chemotherapy works.
Check this one.
It's amazing. And it's like we do.
Yeah.
Okay. Can we go further? Okay. One of them is vitamin D, and that's an interesting part as well, because a lot of people suffering from keloids, of course, have darker skin, have low vitamin D. And vitamin D is involved in all the processes, and I think we hear more of it from Dorothy in this congress. So vitamin D is something to remember, that people have to take that. Okay, when we do surgery, we know that if you do only surgery, then the recurrence rate is way too high. So never do that alone. And if you combine it with something else, then still you have a recurrence rate. I think the recurrence rate is still too high. And what we did is we excised keloids and we did cryotherapy. One of my students will tell about the recurrence rate and how that went tomorrow. So never do the surgery alone. And we have to know that it's a chronic disease in whole body. And Dr. Wang, who's moving there, will tell in the next talk about that. And cryotherapy, Michael will show you some results. That's something we do as well. And the interesting thing is that when you have a burn wound, you got hypertrophic scarring. But when you have a freeze wound, you never will have a hypertrophic scar. That's some interesting point. And I was thinking about that when I thought about the microbiome. If your microbiome will die when it's below -20. So when you have a freeze wound, it certainly becomes -20. And when you have a burn wound, your own blood will cool, burn. And the microbiome will be killed above 60 degrees Celsius. So probably the burn is not high enough to kill the microbiome, and the freezing is low enough to kill the microbiome. When we did our cryotherapy, we started with the thing in mind that for when you freeze it, there will become crystals. So when you thaw and you freeze again and you thaw and freeze again, you have more crystals and the cells will die. So we started to do our cryotherapy 30 seconds, thawing 3 times 30 seconds in a row. But the treatment was not that very good. So we thought, well, maybe we have to do it 60 seconds. So we did 60 seconds and that was better. And then we combined it with corticosteroids. And then it improves as well. But what I do nowadays is I use the cryotherapy for several minutes. I think that's better to kill whatever has to be killed to treat the keloid and to reduce your kidney rates. But how it actually works, I'm not sure. But maybe it has something to do with the microbiome. And then radiation therapy. There's a low recurrence rate when you do it with brachytherapy instead of external beam. And recent publications show that when you do the radiation within 2 hours, have better results than within 6 hours. And I was always wondering what will happen when you do the radiation, because the fibroblasts are entering the wound at 3 or 4 days following surgery, and the macrophages at 48 hours. What are you treating? What are you damaging with the radiation to prevent recurrence? Well, I discussed this yesterday, and the endothelial cells, they are reduced, but the fibroblasts who are still in the wound, they will change, and all the cells who are in the wound will be changed by the radiation. So your wound environment has changed, and that has influence on the stages afterwards. And I thought, okay, now I believe radiation. And this is interesting. I started to do that just one patient, but this especially from China, from the Asian people, because they're very big keloids. We see that here in Holland as well, but not that often. And then what's interesting is to do biopsies and combine it with external beam. We are used here in our hospital to do brachytherapy, but this is something I think to think about, and especially when we have the session with the radiation therapist, how to do the radiation. Laser. I bought a laser myself because I wanted to know what is laser doing. Because they said, well, you can use laser on keloids. But I tried that, and laser gives an inflammatory reaction. So I think when you want to treat the excess vasculature of a keloid, that's okay, but it gives it always gives inflammation. So what I do a laser through the keloid, and I put some corticosteroids on it. If you not combine it with corticosteroids, you end up with a bigger scar, because I think you have to be very careful to use laser. Well, pressure gives it's possible. Microneedling, which is new, only to introduce drugs, so you can introduce corticosteroids, because microneedling will not give as much inflammation as a laser does. Silicone. Silicone. If you apply silicone on the skin, your microbiome will change. So that's also the way how silicone works. But you can apply it, but when you have a very huge keloid, it hardly works. Of course, when you do a study on it and you put silicone and you measure the keloid, it improves a very small bit, but I don't think that's clinically significant. Maybe when you do the operation and you do some extra treatments, then it's useful to apply silicone. In all the literature and our experience as well, when you do a combination therapy, it's better than a monotherapy. And probably we saw all the different pathways were activated. When you do more than a single therapy, that's more effective, in my opinion. And of course, prevention is necessary to prevent all those cells activating that inflammatory state and so on. You have to prevent it, and when it's small, you want not that you have to prevent it then. So we have to educate all the other physicians that they know this is a keloid. Don't operate it without anything else, because then it will grow. And I think that we have to suppress all the inflammatory pathways. And I was phoned by Galderma this week because they're busy with producing an anti-keloid drug. So I think we're up to maybe some change for our patients, because sometimes it's very difficult to treat. Thank you for your attention.
You'll be fine.
Okay.
You want to introduce it?
Dr. Wang. Is he? Yes. All the way from China. Thank you that you're here.